Okay, you guys, thanks so much for joining. Welcome, Baltimore County Fire Department, EMS Academy. My name is Sean Barinholtz. I'm an anesthesia and critical care physician at Hopkins. I'm an active member of Pikesville, and I have the honor of serving in the medical director's office with Dr. Pollack. On behalf of the medical director's office, including Dr. Pollack and Dr. Guyther, who's with us today, on behalf of the EMS office, Director Shannon, Captain Willits, Captain Stewart, Captain Nats, thank you for what you do. Thank you for your dedication to lifelong learning. A big shout out to Ashley Brooks, who's helping us run the Zoom conference. If you can keep an eye out on the chat function also on the bottom part of your platform, if you hover, you'll see chat. And if you open up the chat, that would be a good idea to monitor that. You can send us questions via the chat, as well as Ashley at some point is going to be sending out an email link for a sign-in. If you want your CEUs, keep an eye out for that link in the chat function. I've been asked to double remind you to please try to be accurate in logging your MIEMSS number. It causes a lot of extra work if we can't find you in the MIEMSS database because you have not been able to give us your accurate MIEMSS number. So if you want to be guaranteed for CEUs, please make sure that you keep an eye out on the chat for the link that Ashley sends, and in the forum, please enter your accurate MIEMSS number. Thanks so much. So tonight we're quite honored to have Dr. Jennifer Guyther. Dr. Guyther's career in EMS spans over 20 years and started at Jacksonville Volunteer Fire Company. She continued volunteering through medical school and residency while also serving as EMS Lieutenant and Captain. She completed a combined residency, Emergency Medicine and Pediatrics, and is currently an assistant professor in both departments. She currently serves as the co-director of the combined Emergency Medicine Pediatric Residency Program. She also serves as Assistant Medical Director for Baltimore County Fire Department, Deputy Medical Director for Baltimore City Fire Department, and Associate 3 Medical Director for MIEMSS. Dr. Guyther, thank you so much for being here, and thanks for sharing your tremendous amount of wisdom and knowledge. Thanks.
Well, thank you for the invitation and the ability to do this. This is a class that I have had, hopefully this is shared, I think. I've had the great honor of presenting this a couple of times since MIEMSS offered this as a pilot protocol, and I think it's been very helpful. I cannot take credit for initially developing the curriculum that was put out by the volunteers back in like 2015, 2016, but I have kind of modified it as we went along. So please feel free to ask questions during all of this. This is very open. If we go off on tangents, great. I love tangents. This is initially designed for the EMT basic provider, but I think there's some CRTs, paramedics, EMTAs that can all hopefully learn a little bit of something from this, and hopefully we'll have a little bit of fun. So this class was initially developed for the academic lecture discussion portion, and then also a in-person portion, and at the end we'll let you guys know how we're actually going to handle the in-person component, and hopefully we'll make it really easy for you so everyone can go out and start doing, not interpreting, but doing and transmitting the 12 leads. So we're going to go over a little bit about everything that's on here. There is, right, so you notice on this slide we call it an ECG. You may also hear it referred to as an EKG. And it really just depends on how the person learned to talk about it. So they both mean electrocardiogram. The EKG more derives just from the German electrocardiographia. I can't say it, certainly never learned German. But that's why a lot of times you'll see EKG as opposed to ECG. All right, so why is it important and why did it get developed? One of the biggest things is that early identification of an ST elevation MI can definitely improve mortality, right? So we all know, especially in the US, coronary artery disease is huge, right? One of the leading causes of death. And if somebody is having ST elevation MI, getting them to the hospital, getting them to the cath lab is going to decrease their morbidity and mortality significantly. And so the earlier we can identify a STEMI, so the ST elevation MI, the earlier the hospital can start to work on getting their team acquired and get them to the cath lab. There's also some national metrics that get looked at, and one of the metrics that is coming out this year that they're going to closely monitor is time of the initial EKG. So time of first medically capable person of obtaining an EKG, that arrival time, they should have an EKG obtained and transmitted within 10 minutes. So if you have the ability to obtain an EKG and transmit it, or if you're a paramedic and can obtain the EKG and interpret it and transmit it, all of that will be important. In Baltimore County, as you all know, we certainly have a lot of volunteer systems that may be running at a BLS level, as opposed to when you look at Baltimore City, we have a lot of, no longer, but we used to be all ALS, now we're two-tiered. But if you have that BLS level and don't have a upgrade that's quickly available, being able to transmit a 12 lead and having a physician at the hospital interpret it for you and be able to give you appropriate direction may decrease your amount of on-scene time and decrease your time to the hospital. So if you ever want to learn more about EKGs, certainly more than is in this little over an hour lecture, this is my favorite book. People may not appreciate the author anymore, but the book itself, it's one of my favorites, one of the ones that I learned from, but you can definitely, takes a nice, easy, very picture-based view of going through what all of the different waves in the EKG means. So you can get it at the library, maybe if people are allowed to go into the library anymore, or order it online. That's one resource. Another great resource is EKG Weekly, which it does have some free EKGs that's online, published every week. You can go ahead and Google it. And then there's some other books written by Amal Mattu and Dr. Brady that are both excellent resources, are really just books upon, or pages upon pages of EKGs with their interpretation. So the more extractive EKGs, the better you will get. All right, so we're gonna start truly with the basics. And I'm hoping you all recognize this is the heart. Because if not, I don't even know what to do, right? So down here, you have the inferior vena cava, right? Superior vena cava, both of which wind up with the right atrium. Go down into the right ventricle. It gets pumped to the lungs, right? Comes back from the lungs into the left atrium, left ventricle, gets pumped out to the aorta. Some of it goes to the head, some of it goes down to the rest of the body. Right, on here it kind of depicts that on the left side of the heart, you're generally talking about oxygenated blood. On the right side of the heart, you're talking about deoxygenated blood. So just very basic anatomy review. All right, then we have to move into the electricity of the heart, right? The other one was the blood flow. Now we're talking about electricity. In a normal, wonderful heart, right, your electricity should start at the sinus node, then come down to the AV node, and then you can go down and you see these bundles branch off, right? So these are also different electrical systems. Only important to understand that there's an electricity pattern, and that electricity pattern is going to be reflected in the EKG. For the purposes of 12 lead acquisition, you don't need to know much more than that. When you get into your being a CRT, being a paramedic, that's where you're going to learn how the conduction of electricity between these is actually reflected in the EKG itself. All right, so the next couple of slides I did borrow from Baltimore City's curriculum that they teach, and they have a contract with the company that's on here, StartBeat. So I didn't steal them, but I borrowed them from the city. So down here at the bottom is your EKG paper. Up here is going to be the picture of the heart for the next couple of slides, right? Sinus node fires. This is just basic overview information, not going to have any effect on the EKG lead itself. The atria depolarize, so conduction of the electrical system. You wind up with a P wave. You down, you get to the AV node, right? So energy goes through the AV node, but it actually doesn't transmit into the EKG. It just gives you this little tiny flat segment. The ventricles wind up depolarizing. You get the QRS complex. There's another little brief pause, the ST segment, right? The ventriculars are going to repolarize, the ventricles are going to repolarize. That's what gives you the T wave, right? And then the heart rests and it's resetting. So you may hear people talk about kind of the P wave is like this, or the QRS is wide, or there's ST segment elevation, right? So all those are important things that we start to look at on the EKG. Again, don't worry about kind of memorizing this or anything. It's just to give you a little bit of background information. This, I have always thought, is the most confusing slide in the world, and I've always included it because I want you to understand kind of the way the electrical system is picked up by the EKG. So when you do the 12 lead, you're going to have stickers placed on the body. You're going to have the limb leads, and you're going to have some that are the precordial leads that wind up going around the heart. Basically, what all of these leads are doing is looking from the center of the heart out to where the lead is, and that's how you get the electrical conduction. I don't want to spend too much time on this because it's not kind of in the purview of this course, but if you wind up taking a more advanced EKG read, they will go into all the details on this slide. So this, I think, gives you a little bit better picture just in the effect that it's the camera kind of looking at the different electrical activities. And so as you go through the EKG, each lead provides you with a different camera view, essentially, of what's going on in the heart. All right, so if you've seen a 12 lead printed out before, you're gonna see something that looks like this. This is kind of how the life pack prints it out. You're gonna see it different in the hospitals. A lot of times there'll be 2 more leads down here that kind of provide a full 6-second view of that. You'll notice there's a place for the name. That's super important. We're gonna emphasize that on the end just for documentation purposes. And for the age, some will also come with an ID number. That's more from the hospital standpoint. You notice you can also have an option to enter the sex. Now, this will give you, this box up here, kind of the basic information and interpretation. We will go over to never trust the read that is here. It is never, just take it as never being right. What I will say is if you look at the heart rate, you can certainly trust what the heart rate is there. There are some exceptions to that, but that's okay to look at. And then it tells you the calculations of the intervals. And then down here, you have your leads 1, 2, and 3. We'll kind of go over the placement of them later. Your AVR, AVL, AVF, and then this grouping over here are referred to as your precordial leads. And just an introduction, I don't want anybody to feel like super overwhelmed about this. All right, so let's talk a little bit about ACS, right? Acute coronary syndrome. You have a bunch of different coronary arteries that are around the heart, right? There's different branches of them. And depending on what happens in them, it's going to affect a different area of the heart. So here you see kind of plaque buildup. And so one way to have a heart attack is you have plaque buildup, plaque buildup, plaque buildup, and then eventually it cuts off everything, right? So this became completely clogged. Another way to develop a heart attack is you've been building up this plaque, and then a bit of plaque breaks off and goes and clogs somewhere upstream of that. So either of those 2 ways, you can have a heart attack. The ones where the kind of plaque is slowly building up, think of your patient who is, you know, maybe in his 50s or 60s and says, well, I do really well, and then I walk like a mile, and by the end of that mile, I'm developing this squeezing chest pain in there. That's, you know, these arteries are narrowing under stress and that plaque is being pushed together. Whereas the person who, I was sitting here and all of a sudden I developed this crushing chest pain and pressure and I've been fine, that may be more of a plaque rupture. Now, in the grand scheme of EMS, the difference in your treatment of those 2 things is completely the same. So you don't necessarily have to pick that up. It has to do with kind of downstream how the physicians are going to modify their activity after that and what their risk factors were. So let's look at the typical symptoms, right? I think if I told any of you or your children or somebody who's totally not medically trained that you are a 70-year-old gentleman with a history of high blood pressure, hyperlipidemia, and I developed left-sided chest pain that started radiating down my left arm and up my left neck, associated with nausea, vomiting, and sweatiness and trouble breathing. And pretty much everybody would say you're having a heart attack, or at least I hope. So those are the typical symptoms. Those are the people who decided to read the textbook of everything. So chest pain or discomfort. They may not say pain. They may just say, I have a funny feeling on that side of my chest. They may say, I'm just having trouble breathing. And they have unexplained sweating here. So that's really important. If you ever see a sweaty patient, regardless of their age, regardless of, what their medical history is, you should be sweating, right? People, if they just went and ran a marathon, okay, they're allowed to sweat. But if they're just sitting there and there is sweat pouring off of them, you should be worried that something is going on. Now, it may not be a heart attack, but they definitely need to see somebody medically. Some of the atypical symptoms, right? So just jaw pain or arm pain, just shortness of breath without any other associated symptoms. They could present altered. They could have nausea, vomiting, lightheadedness. There are case reports of, people coming in with a toothache that turned out to be the radiation of their chest pain or toe pain. We had a gentleman that presented to university the other day that proved quite difficult. EMS had gotten called for a gentleman with altered mental status and was just laying on the floor. And of course it was like early morning, so no one had seen him for a while. And he had a GCS of, 13 or 14. His only medical history was seizures. He was on some anti-seizure medication, and his vital signs, he was a little bit hypotensive. So in like the 80s to 90s systolic, and his respiratory rate was a little bit high, like in the 20s to 30s, and his heart rate was fine. And they put him on a 12 lead, and it showed an inferior ST elevation MI, which we had some issues with communicating with the hospital. But once he got there, he wound up going to CAF pretty quickly. We had to, of course, address his respiratory status and make sure that he didn't have a head bleed, because he was altered and nobody really knew whether he had a seizure or anything like that. But it was a very good pickup. He wound up going to the cath lab, and it turns out he actually had a clean cath, but it was temporary ischemia that was related to cocaine use that they ultimately determined was his STEMI. And he wound up actually dying of a stroke. That's what they figured out his altered mental status was from. And he had acute kidney injury and rhabdomyolysis that was likely related to his cocaine use as well. So super, super sick patient, and definitely didn't present with I have a lot of chest pain, shortness of breath, and trouble breathing. So always have a high suspicion and have a very low threshold for obtaining an EKG. The women tend to present completely differently than the men, right? Men tend to read the chest pain book a little bit more. The women and those with history of diabetes tend to present with, I just, don't quite feel right. I feel sick, or I just feel a little bit nauseous. Abdominal pain can also present as a STEMI. I think if you ask any emergency physician, we could come up with 10 stories of patients who presented very oddly with their STEMIs. All right, so some of the risk factors, one of the biggest risk factors is if you've had a heart attack in the past, this is probably another heart attack, right? You can say that for pretty much any condition that you guys see. So if you see a patient you're concerned about a stroke, well, have you had a stroke before? Great, it's probably a stroke. Diabetes, a very good risk factor for having a heart attack. Hypertension, high cholesterol, being overweight, being a smoker. We can throw some other more atypical risk factors in there. So HIV is pro-thrombotic in a lot of situations. Polysubstance use, mainly because cocaine is laced into a lot of it. So about 5% of patients who present with chest pain related to cocaine will rule in for some sort of either NSTEMI or STEMI. So that's important to ask those questions. Many times, since you guys are alone in the back with no family member around them, sometimes they're more honest with you than they are with that. Although I know it's not a typical EMS-based question in your heart patient. It's something when I'm in the back of the medic, I always ask, but a lot of times that's just me. Right, are there any questions before we move on? A lot of times this is like the more conversational part of the presentation. So if there's any questions, feel free to either unmute or just pop them in the chat box, and we'll answer them, because normally I go around and make everybody answer kind of a risk factor or a presentation, but I won't do that to you all today. today. All right. I like this slide mainly because it's fun to use for reference. So here you have the EKG, and what it's overlaid with is what portion of the heart is affected. And so you'll notice when we say there's an inferior STEMI, you're going to notice changes with ST elevation in leads 2, 3, and AVF. When it's involving the septum, so the middle part between the ventricles, you may see more changes in V1 and V2 in terms of elevation. The lateral leads are V5, V6, and jumps over to lead 1, and it shares a little bit with AVL. But these are nice groupings to kind of keep in the back of your mind. So if you see kind of an ST elevation in all of the leads, that may be different. That might be something like pericarditis as opposed to STEMI. But from a pre-hospital standpoint, you're going to treat it exactly the same way in terms of obtaining the EKG, transmitting it, and letting the hospital know. All right, and here's just a nice heart overlaid with the different areas. So if you wind up having an inferior STEMI, this is the portion of the heart that you're taking out. The septal area, the anterior area, and the lateral area. And you'll notice this is your aorta right here. And then here's your superior vena cava coming into the right atrium. Just to give you a little bit of landmarks.
There is a question in the chat.
Yeah. Hold on, I haven't found how to find it yet.
So sorry. So if you do hover over the bottom of the platform, the chat should pop up, or the icon right in the middle. I'm happy to read it to you as well.
Can you read it? Can you read it to me?
Yes, of course.
I don't know why I can't.
How about in women having sudden massive heaviness in body or limbs, or sudden massive fatigue?
Definitely obtain an EKG on those. We've all seen it. That's a great one to bring up as well. Women are weird. I will admit it, and I can say that because I am one. But anything that doesn't fit the picture of what you're thinking, obtain an EKG. So in the hospital, if you think about it, to obtain an EKG, and even for you guys to do it in the field, right? It's 12 stickers, give or take, and a push of a button, a tiny bit of electricity, and a tiny bit of printer paper. It's really quite cheap to do, but the information that you gain from it, or that somebody interpreting it for you would gain from that, can be invaluable. So the other thing that I always emphasize is, let's say the first EKG looks fine and you transmitted it to the hospital, and the hospital says, okay, looks great, we'll see you in the ED. That's fine. If something changes with the patient, they start developing worsening pain, or maybe they were pain-free when you obtained the EKG because it was intermittent, get another EKG, right? So that's one of the best things in the hospital. If we're a little bit unsure of, maybe this lead looks a little bit funny, or there's a little bit of elevation there, but there's no depression that goes along with it, then 15 minutes later, we get a second one. And a lot of times you'll see those dynamic changes. And those changes are even more concerning, that something is actively going on and they need to get to the cath lab. All right, so you guys should all be familiar, hopefully, although it says LifePak 12 on there, most people have the LifePak 15 at this point. And what I encourage you to do when you go to your stations is just go get the monitor out. If you have a friend that's ALS, have them go over it with you. Certainly there is, depending, I've been out of touch with a lot of the different volunteer stations in the county, but if you're not, a lot of you may be using this in AED mode for defibrillation in general on your arrests if you're not running ALS. So I encourage you to become familiar with, one, how to do that, put it in BLS mode. But if it is in BLS mode and you are assisting a paramedic, it is also really helpful to get it out of ALS mode, or get it out of BLS mode and into ALS mode, because that's where you're actually going to be able to how your paramedic's going to be able to, defibrillate based on the rhythm that they see, and things like that. We had a couple of QA issues in the city where there was a BLS crew and their monitor happened to be in BLS mode. The patient was in cardiac arrest, of course, attached to the monitor that came with the BLS unit. And when ALS got there, they didn't know how to get it out of that mode. And so they weren't able to see what the rhythm was, interpret it appropriately, and shock or not shock, change the energy, things like that, which could really be a detriment to those patients. So actually the county helped me out in figuring out how to change it, because we asked all the QA people and they were all paramedics. So none of them had ever actually entered from a BLS mode into an ALS mode. So just be aware that that is an issue. And depending on how your life packs were programmed will depend on how you actually get it out of those modes. So it's jurisdictionally different. All right, so what is there's a 12 lead acquisition protocol, right? So we all know the 2020 MIEMSS protocol updates are out now. So there's two areas where you can look in the protocols for it. The one is the actual 12 lead acquisition protocol that is the same for, it's under the skills section. So it would be the same to obtain an EKG, whether you are a paramedic or a BLS provider. The skill set is still the same. And then there's also the pilot protocol for BLS acquisition. And I encourage you guys to kind of Google, type it in, it'll go through what the exact purpose is, which we've kind of already discussed, the presentation, typical versus atypical, and then what are the indications, contraindications, right? Let's face it, there's really no contraindications to obtaining an EKG. I do it all of the time. Sometimes my nurses get quite annoyed with me because I'm like, they have toe pain, let's get an EKG, why not? And we'll go over the actual procedure. They talk about kind of the QA process that's involved with it. So this is, because it's a pilot protocol, it is technically 100% QA. Unfortunately, with the, not invention, but now that everybody's on EMEDS, it's very easy when you go and put in who did the skill, that checkbox goes to your EMS officer and they're easily able to take a look at the EKG and make sure that the quality of the EKG is there. All right, I'm gonna jump out of this if I remember how to do that, only because I did kind of cut and paste some of the protocol, but I did pull it up actually through MIEMSS website, so you guys could take a look at it in real time. I will say MIEMSS is making a great leap into try to decrease the amount of pages in the protocol. So last year, this was on page 409, and this year it's on page 370. So look, we are making a lot of progress in this. But the biggest purpose, and this, is a nice take-home point for you guys, it's really to reduce the time to get an EKG and hopefully reduce ischemic time to the heart. That is the biggest thing. Right. We talked about presentation. I'm just gonna scroll down so you guys can see this, right? So any patient with chest pain, or you think they're having a heart attack, or there is a strong concern. The other time when this can be helpful is if you're riding with an ALS provider and they want to get an EKG for whatever reason they want to get an EKG. Guess what? You can help them. You can put the stickers on, and that can save a lot of time. If they're going to draw up another medication, maybe this would not be in the realm of the BLS pilot protocol, but maybe the patient's complaining of palpitations or lightheadedness or dizziness, or something where they want to check for an arrhythmia. Right? If you are the BLS person, your ALS colleague can be, I don't know, putting in an IV or drawing up a set of drugs. You can put the monitor on and then they can interpret. So it's a nice kind of skill to have from that standpoint. All right, so.
And there is a question. So it says, if BLS providers can't interpret the EKG, do we leave the area blank where it says provider interpretation? How will that get Q&A?
Well, you should never be, as a BLS provider, you should never be interpreting it. So yes, that should be blank. Please do not fill in what the top of the EKG says, because it's not right. And I have never tried to do that. Does it give you an area to just leave it blank? Is it one of the required fields?
I certainly don't recall. We could see if this person responds again. Jay Lanzi, you're welcome to unmute as well. It is a field there.
Yes, it is a field there underneath where it says the EKG performed and the interpretation, but I don't remember or recall if it says that once you put the ECG in there, if it has to be filled in with an interpretation.
I don't believe it has to be, but if you notice that it's not letting you click out of it, then let your EMS officer know, because that's something that the training office should be able to adjust.
And
Okay.
Craig Millen responds and says, I believe that it is a required field if you do the procedure. So we have some Baltimore County folks online. We certainly can look into this and follow up, but I agree that I support your thought that, yeah, we should not be encouraging BLS providers to interpret EKGs. So we'll have to make sure that's not a required field.
Yes, so thank you for bringing that up, because that's something that, unless you're physically doing it on the form, not something that I'm going to be aware of. The biggest thing is, right, you should not run into the patient's house and be like, okay, let me put the 12 lead on the patient. You first want to initiate general patient care. So you're still going to do your ABCs, you're still going to obtain your blood pressure and, you know, if they're diabetic, your finger stick and things like that. And then what you need to decide is, okay, am I going to do this 12 lead inside the house, or am I going to get this patient back into the unit and do the 12 lead there? One thing, you know, certainly if they're on the side of the street, hopefully you're not going to expose their chest, you know, in the middle of York Road or something like that. But
Now I'm thinking about it again, reading.
they're in their house. They may be. You also have to kind of take into consideration, is ALS on their way? Am I in, you know, near the Pennsylvania line and I have EMS 7 coming to upgrade me? Maybe I don't, maybe I want to get the patient moving towards a hospital as opposed to, you know, waiting for them to come all the way out. Maybe I want to rendezvous with them. Certainly each situation is different, and I encourage you to kind of think about that. And once you do think about that and act on it, when you're ultimately documenting why you did what, make sure to document your decision making. And there's no right or wrong decision in a lot of these. We just want you to think about it. Right, so you're going to put the patient, theoretically, we'll talk about this in a little bit, you know, laying down or in a nice comfortable position. You know, they shouldn't be like laying on their side or anything like that. You're going to put on the chest and limb leads, which we'll go over, turn on the monitor, set the patient age and patient identifier. So typically that's going to be their first and last name. This is not only important for you guys to be able to make sure it syncs up with your report, but imagine sitting at the hospital and having, you know, you're at a busy place, you're at St. Joe's, right? So you're going to get all these cardiac patients anyway. And the EKGs just keep printing off because it's, you know, a Monday afternoon, Monday evening, and now all of a sudden you have 8 pieces of paper that all have EKGs on them, and you have 8 patients and you have no idea which EKG goes with which patient. So this does become part of the hospital medical record, and ultimately it should get like a patient sticker on it and things like that. That's all the hospital's responsibility, but it is super helpful if you have that patient identifier in there. So you're going to acquire the 12 lead. Because you guys are BLS and are not interpreting it, it is very important that you guys consult at that point.
Hey, Jen.
Yeah.
So there's definitely some comments back and forth for people to read. Captain Stewart in particular says that it's not a required field for us. And then another attendee says, I'm still seeing the purpose slide. Is that correct?
No, but theoretically, so the way I'm seeing it on my screen is I pulled up the Maryland protocol, which is outside of my PowerPoint.
Sure. So if you want us to see that, I can walk you through it for sure.
Actually, I have it in the PowerPoint. I just didn't have the 2020 version, which is in theory the same. But let me get back into the slides, at least on my screen, and then it'll help the rest of you guys out. Sorry.
Yeah, or you could share your screen if you have a different window open.
I'm learning all about Zoom.
On the bottom of the platform next to the chat function, There should be an icon that says share screen.
Yeah.
And then that pulls up the different screens that you have open, and you click on the screen you want to show. So right now it shows indications and contraindications.
All right.
Is that what you're working from?
Well, I changed back to the other ones, but like, let's see. Oh, and it says new share. Look at this. This I never knew about this.
You're rocking it.
I am. It's great.
Great.
Thank you.
go.
All right. So you guys should be seeing part of the protocol now.
Yep.
Hopefully. All right. So sorry if I lost a few people there. I didn't mean to. But here we talked about, so set patient agent identifier. It's actually in the protocols. It says it. I'm not just making it up. And then consult. So anytime you guys are obtaining a 12 lead and you're by yourself, you're going to transport that patient because you're 2 minutes from the hospital, or you're in the process of rendezvousing with an ALS unit, you guys need to consult. That also alerts the physician to go and look at their computer. So at university, for example, the 2 attending computers have the EKG software on there, and the it'll blink anytime they're doing that. But if the physician is in a patient's room, they may not notice that right away. So if you call them, then they're going to go to the box, answer it, and then they're going to be able to go look at the appropriate EKG. That's done. If you are doing this as a assist to an ALS provider, or you have ALS on the scene, I leave that between you and the ALS provider. Theoretically, they are taking over care or assuming care of the patient at that point, and they have the ability to interpret that. So err on the side of consulting. If you do transmit, consult. Kind of those are my words of wisdom from there. And then, of course, continue patient care, right? So don't just be like, okay, I transmitted the 12 lead, bye, see you later. And please don't ever tell them, even from an ALS provider standpoint, okay, your EKG looks good, you're not having a heart attack, right? So even if your EKG is read by the paramedic or by the physician as completely normal, that certainly does not exclude a heart attack at that moment. It may exclude ST elevation MI, but there is the whole category of non-ST elevation MIs that you're going to see based on blood draws, frequent EKG monitoring, and things like that. Because certainly a normal EKG 20 minutes later could turn into an ST elevation MI. And there's some other kind of more subtle things that we look at to look for signs of ischemia or coronary artery disease on the EKGs. I've had a lot of QA issues that have resulted in people telling patients that their EKGs are normal and then having bad outcomes. So I'm very paranoid about that as well. As you kind of scroll down the protocol, right, I'm going to jump back to the other thing in a minute, but what it says here, right, acquisition should take no more than 5 minutes. This is a really quick skill. Once you get comfortable with the landmarks on the patient, you should be able to quickly put the stickers on and do everything. Honestly, the thing that takes the most time is when you're scrolling through the alphabet to spell the patient's name, especially if it's longer. Everything else, and maybe taking the clothes off the patient if it's in the middle of winter and they have 18 layers on. Those are probably the 2 rate limiting steps to everything. All right, I'm going to jump back into the PowerPoint. Now that I've hopefully become an expert at the screen transition thing, we can do it. All right, so we talked a little bit about the indications and the contra. So are there really contraindications? No. I will say that we did get sent one, and I'll show it to you a little bit later, of a patient in cardiac arrest that was not return of spontaneous circulation where they obtained a 12 lead. Probably not in the city. This was sent from somewhere else. So don't do that. Certainly if the patient gets return of spontaneous circulation, that is an indication for a 12 lead, but hopefully you also have ALS there at that point. ABCs take priority, right? So if you're bagging a patient, then you should probably bag the patient as opposed to obtain the 12 lead, right? You can get to that after you've maintained their airway. checking the glucose is important. Extrication from the car. I don't think we necessarily need to identify the STEMI of the patient with their legs entrapped, because guess what? They're not going to the hospital yet until you get those legs out. Or the patient is in a super dangerous position, right? So don't risk yourselves. So although they seem like crazy contraindications, they were probably written in there for a reason, meaning someone tried to do this at some point. And so it wound up in the protocols.
There is another question. If we initiate a 12 lead without ALS on the call, do we have to request ALS or can we just transport?
That is a great question. And I would say it's going to depend on your circumstances. If you have suspicion that the patient is having a cardiac event, I would definitely request ALS, because you never know if they're going to arrest, become hypotensive, need fluid, something like that. However, if you are closer to the hospital than ALS, or you need to rendezvous with ALS, that is completely appropriate. And I would just ask that you document that decision in there. Nobody's ever going to come down from you, if you are at York and register and you're waiting for EMS 7 to upgrade you. You're going to be at St. Joe's in 30 seconds. There's no reason to wait for ALS in that case. I would let the hospital know that you're just a BLS unit, because oftentimes the hospital will wrongfully assume that you're ALS and may ask you to do things that are outside of your scope, and sometimes they get a little confused and need some re-education on that. I always recommend that if you have the suspicion that your patient is having, an ACS or something like that, then it should probably be an ALS call. But I would never hold that against anybody for transporting. All right, so when do you need to?
I don't like it.
Okay, so limb lead placements. So there's two versions of this, and quite honestly, I have heard from cardiologists both versions as being their most appropriate and most desired way. And so I would ask the paramedics you ride with which way they prefer. They learned a certain way for a reason. I have one paramedic that if you do not place the leads this way, he freaks out beyond belief. I learned to place your limb lead centrally. So your limb lead consists of your right arm, your left arm, your right leg, and your left leg. And really, as long as the limb leads are between the wrist and the shoulder, or the shoulder and the elbow, depending on which picture you like to use, and that these are, the leg leads are between the ankle and kind of the thigh, you're good. I was always taught this picture, mainly because people's arms are moving around, their legs are moving around, and so the closer you put them to the center, the less artifact you may have. That was just how I was taught. I've asked kind of our techs at the hospital, because they're the ones who do most of the EKGs for us, which way they were taught, and I got 50-50 answers of which way was which. So I don't have a good standardized answer for you. I do always try to put them, either both kind of close or far away. I don't have like one in this wrist and one up at this shoulder. All right, so looking at the chest lead placement, this is probably the more difficult of the two that you're gonna do. So remember, these are your precordial leads. One important thing to do, for one thing, right, go back to the other slide really quick, make sure that it's actually the patient's right and the patient's left, which, depending on which way you're standing, can either be the same. I oftentimes, just based on where the monitors are mounted in the city units, I'm normally at the head of the patient when I put it on. But if you are standing next to the bench seat, you may be facing it. So keep that in mind, because certainly switching the left and the right can change what the EKG looks like completely and may cause a misinterpretation. All right, so when you're getting down to the precordial leads, here's your anatomy. Certainly in a heavier patient or a large-breasted woman, it can be a little bit difficult to sort out some of these landmarks, but your sternal notch is right up here. Here are your clavicles. right? So you are going to go down, I have it written out in words right here, just so it's a little bit easier for you guys to see. V1 is going to go in the fourth intercostal space on the right side of the sternum. V2 is going to go directly across from it on the left side of the sternum. So these two should be a straight line. Then the way I do it, and again, this is just the way I happen to learn, I jump down to V4 next. So V4 goes in the fifth intercostal space, mid-clavicular line. You have nice landmarks there. And then I go over to V6, which goes in the same kind of straight line around the body. So not exactly a straight line, but the same level in the mid-axillary line. And then I go back and I put on V3, which is midway between 2 and 4. And I go back and put in V5, which is on the anterior axillary line. In general, give or take, it's going to be pretty in between V4 and V6. This is probably the most difficult part to get used to, and I encourage you, if you have close friends at like real people, as opposed to putting it on a mannequin body, can sometimes give you a little bit easier way of understanding and visually seeing it, but to play around with kind of this placement, because the placement is the most important. If I do an EKG that has the leads placed in exactly the same position as this, and then somebody comes and maybe they're a little bit off, their V4 is down here for some reason just because they miscounted, and their V6 is over there, those two EKGs are going to look completely different. And I may start to think that there's something going on that's not really going on. So that's why placement is so important. I also encourage you, once you put the stickers on, just to leave them on until you're done transporting, right? In case you need that second EKG, for one, you don't have to take the stickers off the patient again, but you also don't have to worry about those little snaps pushing into the patient. You can just go and hit the reacquire EKG button, and it'll be a little bit easier for you.
So there is another question. If there is a double amputee patient, where is the next best place to place the leg limbs? I've seen ALS providers place them on the belly area.
Yeah, I would say is the lower belly, like hip area. But you're right, you can't put them on a limb that doesn't exist. So I think as long as you are below your precordial leads, preferably down here in this area, that part's fine. And especially in the winter, right, they have like 18 pairs of socks on, you have a nice pair of pants, you have a belt, you have like 8 layers of shirts, you've managed to pull up the shirt. Sometimes the only accessible area that you can physically do in the back of the medic in a quick time is probably going to be the hipish region. And so we accept that. You do the best that you can in the situation that you're presented. All right, so prepping the skin. If the patient is super sweaty, those limb leads are not going to stick, or any lead is not going to stick whatsoever. Super hairy people, they do have a razor, somewhere in your medic unit that is designed for that. I have never had to shave a patient to get the precordial leads to stick. Sometimes using either, if there is a lubricant on your unit for some reason, I don't actually know. Well, for like when you would be when your ALS provider would be placing an NG or an OG, there might be some lubrication somewhere. Sometimes that can help adhere a little bit, or sometimes just putting a piece of tape over the lead if you're really having issues getting it to stick. They're a 4x4, or if you have a towel, sometimes to get off the either sweat or dead skin cells or something like that may help your stickers adhere a little bit better too. All right, so this kind of goes over a little bit of the best practices model, right? So like we said before, do your BLS, your ABCs, your glucometer if you need to, your vital signs before your 12 lead acquisition. You don't want the patient laying there not breathing while you obtain a 12 lead.
Another quick question, sorry, before we migrate, I missed the slide transition.
Yeah.
I've always placed leads in intercostal spaces, i.e. following the curve of the fifth. I was taught not to place over the bone. Does this affect the reading?
It shouldn't significantly affect the reading. You have to remember that you're looking at an electrical signal and depolarization coming from there. So the more dense things that you have may affect it a tiny bit. I am honestly, when I learned, I kind of was taught to do it as a scoop right here. So 5, I was always taught was a little bit lower, but looking through all the textbooks, this seems to be where it has been recommended. So I would say probably either way is fine, unless there's a cardiologist on this phone call who has a really big problem with that.
I agree with you for what that's worth.
Excellent. As long as we're in agreement, then we're good. All right, so mentioned this before as well. So decide whether you're going to perform the 12 lead either before you're in the ambulance or when you get in the ambulance, right? And it says here, use electrodes from an unopened package. This is not saying that the shift you took over for opened a pack of electrodes and I should throw them away in the trash because they used them 3 hours ago. This is, I used them 6 months ago because it's on the utility, they're probably dried out. So I would say you don't necessarily have to throw away those other ones. You may just notice that they're not quite as sticky as before. I have some fun examples of why you should not base your clinical decisions on what the analysis does or does not say. So that's coming up. You want the patient to be lying down, ideally. That may or may not be possible depending on how they're behaving and what, if they're in respiratory distress or something like that. You're not going to take a person who's tripoding and make them lay completely flat down. That just wouldn't be very nice. And theoretically in a position of comfort for the patient. They should be warm and dry. Don't do it in the snow. And certainly if the patient tries to die on you when you lay them flat and they were doing better when they were sitting up, sit them back up, right? So that's not rocket science here. And they are very excited to do BLS before 12 lead acquisition. All right, so this kind of goes, this is the way I was taught. Unfortunately, the last time I taught this class was at Kingsville back in January, and just had this issue come up in the city, the QA case I was explaining before, trying to get out of AED mode. So I was very fortunate that some of the members out in Kingsville were able to help problem solve for me. And we did realize that the city does work a little bit differently than the county, just in terms of the way their life packs are programmed. But if you want to get into AED mode, right? So this is just fun learning that I had. You're going to push the analyze button, push energy selection, and then push the home button. Sorry, that's getting out of AED mode into ALS mode. So analyze, ALS mode, energy selection, and home. And I encourage you to play around with this if you are using both modes at your station, just so when you actually need to get it into the mode that you're used to, you don't freak out. All right, so adding patient information. And I encourage you guys to go through this because I would never expect you to actually listen to this once and then be able to go play with the life pack in front of you and be able to do this if you're not used to doing it. So get the information in there. You're going to push the options button, which is on the right side of the monitor. You're then going to go scroll down to patient. And when you turn the dial in order to select, you typically push in. Right, so then you're going to use and push the speed dial to select the line desired, right? So last name and first name. Then you're going to use that dial to highlight the letter. And if they have a really long name, you're scrolling through to like Z and pushing, and then going to A and pushing, either way. And then you can get down to the patient's age, which is also a scrolly button. All right, so now you've entered the patient information, which we already said is super important, especially to make sure that that EKG matches up with the appropriate patient at the hospital. And then you're going to press the 12 lead button, right? The stickers are already on them. You've already had it set up. And then you're going to have the patient remain completely still. So this is one of the reasons that you think, performing this in a house may be a little bit better than driving down. I can't think of a horribly bumpy road in Baltimore right now, but I know they definitely exist, right? you're going to get a lot of artifact in there. So if the patient's moving, if they're shaking, if they just have essential tremors, that's all going to affect the quality of your EKG, which may make it harder for the provider who's interpreting it to be able to interpret it. But you're going to have that patient remain completely still. This is also the time where I tell them don't talk. Just kind of, I tell them to close their eyes and relax, because typically they stop doing things if they close their eyes. Right, and then you're going to look at the printed EKG and determine if it's good quality or not. So you're not looking at the interpretation of it, but do you see a ton of squiggly lines that are not the PQRS-T blips that I showed you a little while ago? Is one, lead completely not reading at all? Is one lead just completely uninterpretable and a line of squigglies when everything else looks fine? If it is, you want to try to repeat the EKG. You may just be driving down the back of a road in a medic, so you're going to be able to get what you get. You can't, unfortunately, sometimes you want to sedate the patient to make them still and then obtain the best quality EKG, just not something that we do. Once you obtain a good quality EKG, then you're going to transmit it, and then here they should just keep them hooked up as they are, right, while you're transporting, so that if you need to obtain that other EKG, all you really have to do is push the button again. All right, so looking at quality. So here's a nice quality EKG. You can see there's a P, a QRS, and a T. It's nice and flat. There's another P, QRS, T wave. You can see this generally, if you kind of drew a straight line, it's going to be a straight line through all of those. It doesn't look like this, right, through one of them. So this would be an example of a poor quality tracing or artifact, right? The patient's heart is not really doing all this, whatever those black markings are. That's from kind of just patient movement, or if you yourself are tapping on the EKG lead, it can do something like that as well. So this, if you get an EKG like this, honestly, I have no idea how to interpret that. So I would, if I got that EKG in the hospital, I would ask the tech to go and repeat it. And I would just throw that one in the trash. All right, so to transmit, now that we've said, okay, it printed, it's good quality, right below the acquire 12 lead button is the transmit button. All right, after you press the transmit button, you should get a screen similar to this. So it's going to say send, right? You're going to go down to report and go down to 12 lead. And it can have like 12 lead 1, 2, 3, depending on how many 12 leads you took. And then after you type what you are going to transmit, then you're going to go down and have the site. And depending on how you have your monitors set up, right? This is the way that they come up in the city, because those are the life pack that I use to take the pictures. You might have a code there. You might have the actual hospital name. If you are doing this as a BLS provider without ALS on the scene, you need to transport your patient to the cardiac intervention centers that can review your EKG. And this may not be an all-inclusive list, but these are the ones that come up in ours. And it's not, because university is not even on there. All right, so use the dial to select and then press send. So after you've done those 2 other steps of identifying the 12 lead, identifying where you want to go, now you actually want to send it a little bit backwards in the listing there. And then you're going to consult. All right, here's just another example of, well, a couple of things. So this shows you one thing. I have no idea what's going on down in B6, so this is not the best quality. This was a case that was a, 46, I'm gonna say 46-year-old gentleman who developed acute onset of chest pain and shortness of breath. Fortunately, we had a very good paramedic who was on board, and he noticed that this was an inferior ST elevation MI. Right? So you have ST elevation leads 2, leads 3, in AVF, and you have a little bit of depression in lead V2 as well. Now, you would notice if you just looked at what the EKG said, it said data quality prohibits interpretation. And that's only because V6 is messed up. These other leads, there's a tiny bit of artifact you can see here in this baseline. But other than that, this one's a clear-cut STEMI. What I also did, so this provider recognized that it was a STEMI, but through his course of kind of transport, he did repeat the EKG multiple times. And I just wanted to show you, this is the same patient. So same patient as this, same inferior STEMI, inferior ST elevation, still the same ST depression in V3, but look at the different interpretations that the EKG met, or the EKG read. So in these 3 cases, I didn't put the other 12 leads up just to not overwhelm you, but they all looked exactly the same as this EKG here. They all agree that it meets ST elevation criteria, but here it read it as a regular supraventricular rhythm. Over here, it said it was sinus rhythm. And over here, it says AV dissociation. So here's just some nice examples of why you should never trust what's at the top. I will say the caveat of that, if it says meet ST elevation criteria, it really freaks you out to call it not an ST elevation MI. There are definitely cases where that happens, but I never like seeing ST elevation MI and then me reading the EKG as normal. And it happens. I've done it before. It just makes me feel uneasy. This was another really nice QA case that actually I had, and it was the BLS crew who wound up transporting to Midtown of a lady that was having chest pain, who had an MI in the past, and they, being the providers, decided to interpret the EKG, not transmit it, and they interpreted it as normal. They neglected to see that there was an issue with connecting the leads here. And if you don't actually plug in V1 through V6, that's a problem. You can actually produce this EKG, and this actually I think is my EKG because we lost the initial one because it wasn't uploaded into the system. But this is exactly what it looked like when I saw it the first time. And the actual reading on this EKG was normal sinus rhythm, so I was not dead, which is great. I apparently have a non-specific T-wave abnormality, which I disagree with, and it's an abnormal EKG. So don't believe that. But when this patient got to the hospital, this was their EKG. So a massive ST elevation MI. And I will say, remember, this was me reproducing that EKG. But you can see here, ST elevation in V1, worse in V2, horrible in V3, and in V4, and in V5. And this person went immediately for cath. Well, shouldn't say immediately because they had to be transferred to university because Midtown is not a STEMI center. But had the providers actually been able to obtain V1 through V6 leads and consulted with the appropriate facility, it would have wound up letting the patient go to the appropriate center and being in the cath lab much quicker than adding an extra hospital stop along the way. The last one I'm going to show you actually doesn't have anything to do with ST elevation MI, but this rhythm is called a sine wave, which is typically present in hyperkalemia. So hyperkalemia can pretty much do anything to the EKG. If you see a weird EKG or a really weird bradycardia, they are probably hyperkalemic if you're going to play the odds. This went unrecognized by EMS. Calcium is what you're going to give these people in the field as an ALS provider, and maybe some bicarb, depending on what your IV access is, and maybe some albuterol if you want to go there and are not in the time of COVID. Just to treat the hyperkalemia, but the reading on this was AFib with RVR, which is not right whatsoever. So hopefully now I've proven to you guys never to trust what the 12 lead says at the top. Just transmit it and let the provider at the hospital figure it out. All right, so consulting. I know it can be a little intimidating when you're first starting out. Like if you guys think back to what your first consult sounded like, it's not necessarily a skill that comes readily to some people, and practice really does help. I will say you need to, depending on which hospital you're going to, depends on how many questions they ask. And I do listen to a lot of consults where the hospitals, they pick on the most random questions, and half the time the provider has already said the answer to those questions. So definitely practice your consulting skill, right? You should, anytime you have a suspected STEMI, right, they're a priority 1 patient right off the bat. But when you're transmitting, even if they're a priority 3 patient, you still need to consult. So you're gonna go to EMRC, figure out what channel you're gonna switch over to, right? Get the hospital on the line. Please speak slowly and distinctly. I will say if you're talking about a 8-year-old versus an 18-year-old versus an 80-year-old, a lot of times that articulation gets lost over the radio. So I always suggest saying pediatric patient, 8-year-old pediatric patient, or an 80-year-old, because a lot of times you'll get kind of triaged to the wrong place depending on which hospital you're going to initially. You want to start out with the age, the gender, chief complaint, a brief history. If they have, if they're coming from a nursing home and they had a stroke in, 70 years ago when they were 20, and they didn't have any deficits from that, and they have gout and reflux, right? Gout and reflux probably aren't as pertinent as the stroke, or, things like that. So pick 2 or 3. You don't need to sit there and read off a page of medical history. Medication, you can say you'll provide a list if there's a significant one, such as an anticoagulant or aspirin or nitro or something like that, that may fit in. Allergies are often pertinent, depending on, what the given situation is. If they're allergic to aspirin, please say that. But, if they're allergic to bee stings, probably not as pertinent to say over the radio. Any interventions that you have done, whether they have an IV, if you're an ALS provider, if they're intubated, those are probably the 2 biggest things that I like to know. If you are needing any orders, right, and how long it'll be. Welcome to Zoom. Enter your meeting ID. How long it'll be for you to get there. And make sure that if you are consulting just for them to look at the 12 lead, if a nurse answers the radio, make sure that you have a physician listening. So depending on which hospital you're transporting to will depend on who is base station trained. So university, I think, is the only one in the state who has all physicians answer the radio 95% of the time. We have 4 nurses in the adult emergency department that are trained to answer it. Other than that, there's always a physician on the line. If you go over Hopkins, for example, they don't train their EM residents in the base station class. They just have their attending. So it's either a nurse or an attending. So you may get either one. I typically, because I used to work at a couple of different hospitals, would answer the radio, and I would always say the wrong radio or wrong hospital that I was at, which led to a lot of confusion. I always thought it was funny, but then I felt bad. So those are the kind of key concepts I have for consulting. But practice does make perfect when you're doing that. All right, document all aspects of the call. So I mentioned it before, if you decide to transport to the hospital to BLS level because ALS is too far away, just jot that down. I can guarantee you it will save you a call from your EMS supervisor when they're trying to figure it out. Document your medical decision-making, why ALS wasn't present. Make sure to upload the 12 lead, right? So the hospital should theoretically have a copy of it, but make sure when you're uploading your report that that gets uploaded as well. And all BLS will undergo 100% QA. All right, so typically they will have the practical evaluation in here. I have no idea how I'm adding these lines to the screen, by the way. It's like magic. So the goals is really to make sure that you understand how to use the life pack, right? So whichever one you happen to have, hopefully nobody has 12s anymore, but you might. But know how to use the 15s, know where the extra batteries are, know how to change the printer paper. On a person, identify each landmark that you're using, figure out how you would prepare the skin for lead placement, place the lead, obtain a good EKG that's good quality, and then transmit the 12 lead to the EKG test site. So if we were in person, this would be kind of what we would be doing as a big group. However, we have been fortunate to come up with a plan. So you guys will, or I don't know whether you have it now or you will at some point tonight, hopefully have access to this form right here or something that looks very similar to this. We ask that you put your name, whatever date you are actually doing this form, your MIEMSS number, your career or volunteer number, what station or shift, if that is pertinent for you, if your career, and then pair up with an ALS person. So this could be, anybody who is turned out to be ALS in Baltimore County. And this could be either in a mock situation with a friend, or if you were doing it on a patient, go through the limb leads, go through the monitor operations, make sure you transmit to the 12 lead to an appropriate facility or to a test site if you're not using a real patient. The ALS provider can mark you as successful or unsuccessful. You should sign it, and the ALS provider should both print and sign. Return this to your local EMS office, and ultimately that will be entered in NIFRS. Once it is entered in NIFRS, you guys are good to go and do all the 12 leads that you want in the world. Since this is being recorded, if you are watching this later, once your credit is recorded, then you will either be mailed or emailed this competency form, and you'll be able to kind of complete it at your leisure. All right, so that is all I have for you guys. If you have any questions or want to talk about anything else, I am more than happy to do that.
Jen, there are some questions, so super fast for everyone. Ashley was kind enough in the chat function. Again, if you go to the bottom of the platform and you hover over that menu in the middle, there's chat, and you click on the chat, it should open up a sidebar. From Ashley at 8:02 p.m. There's a link, there's a sign-in sheet, the link for the sign-in, the bit.ly EKG 12 lead, and then you download the attached file that's also in the chat, complete it, and then return it to the EMS office and the form will get entered into NIFRS tracking. The checkoff sheet is also available if you contact your district officer. So if you're on the phone and unable to see the chat, contact your district officer for that. If you have any questions or can't get access to that, send us a chat. So there is a question from Pernell Hammond. When transferring a patient to the ED, is it okay to print and leave a hard copy of the 12 lead with the short form?
Yes, that is definitely okay. It should also have been transmitted there as well, but in the world of printer paper going everywhere, sometimes it's a little bit hard to track down. So I always liked when I got the hard copy as a receiving physician, because it made it a little bit easier for me to track down.
Great. And there's a question, are there certain MIs that the patient should not receive aspirin? With having this training as a BLS provider, should we still give aspirin prior to getting a 12 lead, or should we complete the 12 lead and consult?
So unless the patient has a significant aspirin allergy, then there's no contraindication to giving aspirin in those situations. You do want to be aware of nitro with right-sided heart lesions, basically. But aspirin would be fine. So if you have a high suspicion that this patient is having a coronary issue, then giving aspirin is fine. So you could go either way in that case. But always, some patients do say that they're allergic to aspirin.
And then there's a question, is there going to be an annual refresher for this?
So that is an interesting question that I do not know the answer to. We had played around with that many, many years ago, and the answer was initially yes. I will also say that the practical portion of this and the turnout portion of that was also much more complex when we started that, and we've really narrowed it down. I think the idea is when you do, kind of for career people, when they do their annual skills checkoff or their annual refreshers, to include a few minutes of that in this in some way, certainly a much shorter form. But right now, I don't know the correct answer.
Here's a question. Admittingly rare, can you address placement of leads for a patient with dextrocardia?
Right, so dextrocardia is going to be kind of a reversal of the heart. Basically, it's flip-flopped. A lot of times it goes along with flip-flopped other organs as well. You're basically going to do a right-sided EKG. So you're just going to have that mirror flip and just do it on the opposite side, if that makes sense. Hopefully it does. You can also, just to kind of complete that circle, you can also do a posterior 12 lead. That I'm going to leave up to the ALS providers. Kind of, it's outside of the scope of this simple 12 lead, but you can also look for a posterior MI by placing the precordial leads on the back to take other views of the heart. Hopefully there's maybe only like 1 or 2 people with dextrocardia in Baltimore County. I have no idea, but I'm guessing it's going to wind up being pretty low.
I also just posted on the bit.ly PFC YouTube site, within the past year, we had Matt Goldstein give an amazing talk on EKG. So for those who are interested in ongoing education around that, there's part 1, what an EMT could know and a paramedic should know, more into the using the Dubin kind of methodology. Matt is a exceedingly talented educator, and he did a 2-part series, if anyone's interested outside this program. And then one of the docs from Sinai gave a talk around STEMIs and gave a ton of great EKGs for acute STEMIs and patient stories about patients that we in Baltimore County have taken care of. So those links are available. Those videos are available on the YouTube site, and the link is available in the chat. Starting to get some comments. Great class. Great class.
Thank you, guys. I'm gonna put my email in the text box, and you're always free to email me if you have interesting things you want to talk about that are certainly outside of this class. My favorite things, so like Dr. Bernius, we're both EMPs trained, and so pediatric EMS is one of my passions. But I really like kind of the teaching and QA, QI things. So I'm more than happy to, I like to go off on stories and tangents. So if any of you guys have questions or anything, feel free to email me and I'll get back to you as soon as I can.
Tons of gratitude coming over. Dr. Guyther, thank you so much for sharing your expertise, your time, and your passion for educating others. Very appreciated. We appreciate you.
Great, guys. I hope you have very successful EKGs now that are all really high quality.